Hello, welcome back to another episode of Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare. We are an affiliate of the Kentucky chapter of Physicians for a National Health Program. I'm Mark McKinley. I'm a volunteer with the group. I want to let our listeners know that Kentuckians for Single Payer Healthcare is a community partner here at Forward Radio. And we would ask, if you are able, please go to forwardradio.org and click on the donate button. We could use a few bucks. We're an all volunteer-driven radio station. We've got coming back again, Dr. Mike Flynn and Dr. Eugene Shively. And Dr. Flynn, I'm going to turn it over to you.
Yeah, we have with us today Dr. Jess Wright, who is professor of psychiatry at the University of Louisville. And we're going to discuss mental health issues in this time of pandemic and social unrest. Jess, why don't we give you an opportunity to, if you have any sort of broad or general statements you'd like to make about that, and then we have a series of questions and we'll just work our way through them until we're done.
Well, thank you, Mike and Mark and Eugene, for inviting me to be on your program. I've been looking forward to it and really enjoyed speaking with you about mental health and how the pandemic with our COVID-19 issues has influenced mental health and mental health delivery. There have been huge changes. Within about 48 hours, our clinics moved from about 99.9% in-office visits to hardly any in-office visits. Fortunately, our group at the University of Louisville had done some telemedicine before, so we knew a bit about the technology, but that was just a couple of the docs, so they had to train us up real quickly to be able to do our sessions on what we call Blue Jeans. It's very similar to Zoom if you use Zoom. It's a confidential way of connecting with patients. So that's been a really terrific transition. And in some ways, we think the genie's out of the bottle. That is, that now that we've made this move to talking with people in their homes, making it really convenient for them, many of them are interested in continuing that even after the pandemic is over. We hope it will be over one of these days, but we don't know when it'll be. But they're very interested in that because it's more convenient. They don't have to pay to park or drive down to the clinic. And if you're from a rural area and you're coming to Louisville to see a doctor, it can be a whole day of driving and parking and seeing the doc and having lunch and sitting in the waiting room and so forth and so on. So that's been a big change for us.
So, just hang on a second. Well,
sure.
How do you deal with privacy and HIPAA issues without, so how do you know somebody's not listening in on some?
Yeah, great question, Mike. There have been some waivers from the federal government, from Center of Medicare and Medicaid Services, to allow communication without the stringent controls that we've had in place for HIPAA. However, we are trying, if we possibly can, to make connections through secure links. And there is a Zoom and Blue Jeans and other services. One of them is called Doximity, spelled DOXIMITY, set up for physicians, in which the connection is secure and the chances of someone so-called listening in is extremely low, better than a phone call. So we're aware of that. Right now, Medicare and Medicaid and many states are allowing even FaceTime use just to have people have access to care given the emergency situation we're in. So in some cases, we resorted to that, but we try to get a secure communication if we possibly can. But what we've seen is our volumes, that is the numbers of people who want to be seen and get some treatment for mental health, are staying really pretty high. In fact, there's a lot of new cases that are coming our way of people that are searching out treatment. One of the things that we have to make sure we're getting across, and maybe the radio program can do some of that, is letting people know we are still in business and we are still taking new evaluations, although we're doing them virtually by video link or by sometimes even telephone. So there have been a lot of changes also in the complaints that people have and the issues, as you might expect, and I'd be glad to dig in deeper to that as we go on with the questions. I think that there are many people that the COVID-19 situation has caused pretty dramatic increases in social isolation, loneliness, anxiety, depression, potentially misuse of alcohol and drugs, changes in their diet, lack of exercise, lots of things that are going in the wrong direction as far as mental health. So again, we can talk about this as we go on.
Sure. Well, why don't we just start, let Gene, Gene's been down in Campbellsville for since the beginning of time, and he's practiced down there, knows it well, and has got some questions about, the mental health issues in this time as when you put it into a rural environment.
Sure.
Well, we've always had a problem with mental health in rural Kentucky. For example, if I admit a patient who has a surgical problem and he has a psych problem, we can hardly ever get a psychiatry consult. Or if we have a patient that becomes delirious after being very, very sick and is in the ICU, we just essentially have to take care of these problems ourselves. Another problem that we have is we have patients who come in with mental illness in the emergency room, and it's extremely difficult to get these patients transferred. I wonder, do you think that telehealth will help in solving some of these problems?
Well, it has huge potential to do it. I'm not sure how much it's helped yet with that. You put your finger on something that's really important, Eugene, and that's access to mental health treatment. It's important in rural areas. It's important in disadvantaged populations. Even in urban situations like here in Louisville, where I practice, there are certain groups of people who are less likely to get the treatment they need for lots of reasons, a lot of barriers. Some of them are stigma, insurance, finances, attitudes about mental health, you name it, that we need to figure out some way to overcome. If we look at the frequency of mental health issues in people in the United States, it's dramatically high. Just to give you a couple of statistics, the lifetime risk for serious depression, we call it major depression, meaning you need to get help for it. You need to see a doctor, you need to get on medication or have some therapy, or both. That's 17% of the people in the United States. 4% have bipolar disorder. When I was in medical school, we were told it was about 1%, but it's really much higher. So there's a lot of that out there, and these people all need sophisticated help for their illness, to be able to choose the right medicines and to manage things properly. Anxiety disorder is even more common than depression. If you add it all up, you have perhaps half of the people in the United States that could benefit from getting some mental health treatment, but the statistics show that not very many of them are getting the help they need. In the year after a depression starts, less than half get any treatment at all. And that's across the board. And if you go to a place like Campbellsville, where you've been practicing, the situation's worse. I can tell you that I do a fair amount of telemedicine. I was doing some before the COVID-19. I was doing phone sessions and so forth, and seeing people that drove up from places like Campbellsville or other rural sites in Kentucky. And I'm very interested in doing that whenever I can. I come from a rural area in Pennsylvania myself, a little town of 6,000 people. So I know what it's like to grow up in a rural environment and not have access to care. And I still go back there and see family and friends and enjoy being in that rural environment. But it's a tough situation. So docs like you that are in that kind of environment really need to learn how to assess a delirium and assess suicidality, and make the best choices you can without ready access to treatment. If you're in Louisville, you're lucky. We can get access in most hospitals with a consultation. If it's an outpatient that needs emergency care, they can get to University Hospital, to the emergency psychiatry services, and there's a full-time psychiatrist, resident doctors, social workers just waiting to evaluate people and give them help. But that you just don't have those resources in most areas in rural Kentucky and rural America.
So, Jess, so let's just take these two issues, rural and urban, and now in kind of a broad sense, are these issues all the same? Are the mental health issues in Campbellsville essentially the same issues, or are there different issues in Campbellsville than there are in an urban area like Louisville?
The answer is yes and yes. They're the same and they're different.
And that sounds like a lawyer instead of a...
So I'll try to explain that. I'll try to explain what I mean by that.
Okay.
So we have illnesses like major depression and schizophrenia and bipolar disorder and obsessive compulsive disorder and post-traumatic stress disorder and so forth that psychiatrists and general physicians have learned about through the years and know how to diagnose and know various aspects of treatment that often work. But each individual that comes for treatment or has a condition has their unique fingerprint, if you will. No two cases are the same. So I see people with major depressive disorder that if you click down the list of symptoms to diagnose it, they all have the same symptoms, but yet one person, the path to that may have come largely through genetics. They had a huge family history of depression and no real psychological stresses that seem to explain it. I have other people with no family history of depression, and the social setting that they've come out of is a breeding ground for depression. They've had childhood deprivation, financial issues. They've had difficulties in school. They've been picked on and bullied. They have sexual trauma growing up, and they've had current financial problems and health problems. So all these things are going to play into your vulnerability for something like depression and the way you need to treat it. So, for example, somebody that has all those problems and might have difficulties with relationships with a loved one, just prescribing a medication may not do the trick. We need to address some of the issues in their life that are playing into the depression and maintaining it. So it's yes and yes. We do know that poverty, social deprivation, medical illnesses, all these things increase the risk of conditions like depression. So, but depression, on the other hand, does not miss out on people that have everything going for them, that are well-to-do, well-educated, have not had traumas. It can happen really across the board. Okay, well, let's kind of move on to a sort of a similar but kind of different issue. A question of we've talked about this on an earlier show. We have somewhere in the neighborhood of 80 million people in this country who either are uninsured or underinsured. And now, can you give us an idea of how these folks fit into, where do they get health care? They don't have any insurance, or they're underinsured. They can't pay their bills. They can't afford to go. I don't know if they can afford to do telemedicine with you. So, right. How does that? Let me just say a few words about that as it pertains to mental health. Yeah. If we look at the history of mental health treatment, problems with being underinsured have been the greatest with mental health treatment and patients with psychiatric illnesses who've been discriminated against beyond what people with physical illnesses that don't have proper insurance have been discriminated against. I remember when managed care came on the scene in the 90s, and there was a dramatic move to ratchet down the amount of mental health care that could be delivered. I likened it to the psychiatry services were like the first soldiers on D-Day on June the 6th. And we were like basically slaughtered, and the level of care plummeted. It's starting to come back some, and in some states, and there's more work to have parity. There's a federal law about parity, but it doesn't always get played out that way. But we still see discrimination against psychiatric patients, even if they do have insurance. And of course, if they don't have insurance, it makes it even more difficult. One of the things that we might touch on is a huge problem in psychiatrists and other mental health providers, psychologists and social workers, not being willing to accept insurance, even if people have it. And the reasons for that are that insurance often puts all kinds of barriers to mental health professionals. They have to go through all kinds of loops to get approval for their patients to be seen. And then the reimbursement rates are pitifully low. So psychiatrists have trouble, making a go of it, accepting insurance. At the University of Louisville, of course, we accept insurance, and we do a lot of indigent care, so to speak, or people that don't have insurance. And we take people that have insurance, people that want to pay their own way, anybody pretty much that comes our way. But in the community, I've been told that in Louisville, about 2/3 of the psychiatrists won't accept insurance at all. And that's because the insurance is not covering really the cost of care for people with psychiatric illnesses. It's
let me follow up a little bit on that. As you heard from Mark's introduction, we represent a organization promoting single payer.
Yes, I understand. Uh-huh.
Yeah. So we have over 1,000 for-profit health insurance companies in this country, all of which have got, 20, 30, 40 different plans. I'm not exactly sure how many psychiatric options each of those 1,000 different insurance companies might have. But have you got any thoughts about how mental health could be managed in a different way under a single payer system as opposed to, I don't even think we have a system. We have a patchwork of an assortment of different options. Right. Mm-hmm. But I was kind of curious about what your personal views about how mental health would segue into a single payer healthcare system in this country.
Well, I have to give that some thought. I see a risk right away that it could accelerate the move towards psychiatrists for opting out of the payment system. Now, perhaps it would be set up in a way that it would be fair to mental health patients, psychiatric patients, and providers. But if we look at Medicare, for example, the reimbursement rates are really quite low compared to other specialties. So if you converted Medicare rates now to a single payer system, my hunch would be that there would be legions of psychiatrists who would say, no play. If you want to see me, I'm out of the system. So there would have to be some kind of adjustment so that the payment rate would be fair for mental health patients and for their providers. So that would be an issue. In talking about how to do it, there are economies that could be put into delivery of care that might be things to consider for a single payer system. And one of them has to do with work that I've done with research for over 2 decades, and that's to develop ways to deliver treatments, psychotherapies that are effective with much less clinician time. This may sound antithetical because you might think you want more clinician time under a single payer system, but it costs a lot of money to do psychotherapy. For example, if you wanted to treat a case of depression with cognitive behavior therapy, which is a well-known treatment that has over 400 randomized controlled trials, you'd have to schedule about 20-hour-long sessions, which under any system is going to cost a fair amount. So the work we've been doing shows that you can reduce that by at least 2/3 by having patients do some of the work themselves with online computer resources. So I've been funded by NIH with major grants to do this research, and we just finished a trial in family medicine and primary care that showed that we could get really great results by reducing the amount of clinician time, but having patients do interactive training online. So using technology, I know I'm talking with some older physicians here who their eyebrows may go up, but at least in mental health, there's a big move toward harnessing technology to improve the efficiency and the ability to deliver care to large populations of people. This has been all over the world.
All these psychiatrists using all this technology. I mean,
yeah, that's right. You might think of Sigmund Freud and people sitting on the couch for hours and hours and hours on end. But I can tell you that psychiatric treatment is moving quickly toward using a lot of technology and becoming much more efficient to deliver evidence-based treatment that works to many, many, many more people than ever could before.
Well, let me go ahead, Gene.
Give us a little idea of how this works online.
Sure. First, full disclosure that I do research on computer-assisted therapy, and I have some equity interest in two companies that produce software. One of them is called MindStreet, and one of them is called Empower Interactive. I don't take any payments from them, but I do have some stock in those companies that I help to develop the software for. So the way this works is that you have a clinician that guides you, so it's not where you just go to a computer and do your treatment, but you sign on to an online program, and at the beginning of the program, you might have a 20-minute lesson, and at the very beginning, you are ushered into a psychiatrist's office, and you could choose your psychiatrist. I'm on one of these, so you could choose me, or you could choose a woman or somebody else, depending on who you want. And the psychiatrist guides you through some of the things you need to know about depression or anxiety and some of the basic principles you're going to learn in the session. Then you see a video of a person suffering from depression or anxiety who's working through their illness and learning to put new skills to work to manage the problem. One example might be with depression, people are riddled with negative thoughts. They might think it's hopeless, I'm a failure, no matter how hard I try, I'm not going to get anywhere. And then they get really self-defeating thoughts, and they tend to give up, and their behavior doesn't fit with ways to solve problems. So the narrator and the videos are going to help people learn how a person can spot those cognitions that are getting them into trouble and turn them around using techniques with cognitive behavior therapy. So they learn these things, and then they put them to work in real-life situations from their own life, and they get feedback from their clinician about how they're doing with it. They have interactive exercises that are drawn from this treatment called cognitive behavior therapy. So the particular program I'm talking about here, called Good Days Ahead, has 9 lessons. People do it over about 8 or 9 weeks, and they get small coaching sessions from their clinician along the way. They may be taking medication too. But our results have been terrific. We've shown that you can do computer-assisted therapy and equal the results of 20 hours of typical face-to-face cognitive behavior therapy.
Does this also work for major psychosis like schizophrenia and bipolar?
There are some programs for schizophrenia, but it's primarily been developed for depression, anxiety, PTSD, and OCD. And for substance abuse, by the way, but not for the major psychotic illnesses, which would take a lot of concentration to be able to sit in front of a computer and do the work.
Go ahead, Jane.
How do primary care physicians fit into this? Are they can they be taught, and should they play a role since there's not enough psychiatrists?
Right. The role of the primary care physician in delivery of mental health care is extremely important. In fact, most people with depression and anxiety now are treated by their primary care doctor instead of by psychiatrists. Most of this is by medication, but primary care doctors can learn some of the basics of sort of short-term, pragmatic psychotherapeutic interventions. My daughter is a primary care doctor. She's the director of the residency training program at the University of Vermont. And she went to Jefferson Medical College and then did a fellowship at Penn when she was in Philly on mental health treatment in primary care. So she's pretty well versed in how to do things. So she treats people with bipolar disorder and with major depression and anxiety disorder, and does bits of psychotherapy along with her brief interventions with them. And I think some other primary care doctors can learn how to do that too if they have an interest in it, can pick up things that along the way, can study it in medical school, have a residency that gives them some training. But I'd say that most primary care doctors are prescribing medications, and that's good as long as they are on top of it and see their patients regularly. One of the problems we do see in primary care is that the patients probably don't get seen quite as often as they might for ideal treatment, and they might be seen for briefer amounts of time and may not have all the resources. So that's one of the reasons why we've tried to develop this computer-assisted therapy model for primary care. Our most recent study was in primary care. We studied 176 patients that came from internal medicine and family medicine practices, and things turned out really well. That study isn't published yet, but it will be probably before too long.
Just want to let our listeners know that you're listening to Single Payer Radio here on WFMP LP 106.5 with retired surgeons and emeritus professors Mike Flynn and Eugene Shively. And we have Dr. Jess Wright. The topic today is discussing mental health care in America and during our pandemic. And just want to bring up out of an article I read last night that of the $2 trillion that Congress allocated for relief through the CARES Act, roughly 1/50th of 1%, or $425 million, was earmarked for mental health.
I wasn't aware of that. That's very telling, isn't it?
Yes, it is.
Mm-hmm.
Jess, let's back up a little bit to the economic issues and underinsured. And my question is, have you had a direct or indirect experience in some of the other countries that have got different systems, like National Health Service, for example, in Britain? How does psychiatry work there? Do the psychiatrists have the option of opting out of the National Health Service and doing something else? Do they just, because they're all basically, almost everyone to some extent is working for the government. And I know how it works with surgeons over there, because they can, get an office in Harley Street and do their government practice and have a private practice on the side, at Guy's Hospital or someplace like that. But I don't know how it works with mental health and psychiatry. Right.
Yeah, I've had the real pleasure and blessing to travel widely as a professor and to give talks and seminars and workshops in many countries of the world. And I have colleagues in the UK and China and other places around the world. And, the United States has the most fragmented and sort of tough situation for patients and for doctors anywhere in the world, in my opinion. In the UK, where I probably have my closest associations, I've written some books with people from the UK and have traveled there, have done filming there for our books, and have done a lot of workshops with people from the UK. The life of a doctor there is different, quite different. The level of compensation is much lower. Their standard of living is much lower than it would be with American physicians. So American physicians may, be somewhat concerned about switching to that kind of a model if the level of compensation gets down to the level of what's happened in the UK. But they seem pleased and happy with what they do. They are basically paid a salary to treat people with mental illnesses and to do research or the other things they might do, or to teach if they're in an academic position. Care, I think, is pretty good in the UK. It's more organized. There are teams that develop various strategies. I know that there's a big push to train many, many more clinicians in how to do cognitive behavior therapy because it's a useful treatment. And so there's been a big move in the UK to do this, big investment in it, because I think it's going to pay off, not only, by the way, in mental health, but in physical health. And maybe we should touch on that a little bit, then I'll come back to some other countries if you want to follow up on that, Mike. But there's abundant evidence that if you don't treat mental health properly, physical health goes downhill, and the costs for treatment of physical health go up. Just think about that for a minute. If you have a case of diabetes, coronary artery disease, and you're also depressed, what do you think happens with the diabetes, the overweight, the other health kind of choices people make, like how much they drink, how they manage their diabetes, how they manage their heart disease? They go in sync. So it's a vicious cycle. One thing makes the other one worse. So you really have to look at the whole person and treat everything well. So other countries, I think, do a better job with that than we do in the United States, in which we've carved out mental health instead of put it into the total healthcare system. And we have huge problems with insurance and access to care, much more than certainly in the UK.
Yeah, and there's a very different, I don't know if it's a view or a philosophy about the relationship between the citizens in Britain, for example. We were over in over in London last July. It was actually this time in July.
Yeah.
We took a train up to Bath, and took a tour of the Cotswolds. And the driver was a young man named Nigel, and we got into a lot of these discussions as we drove around to these different places. And, one of the things he said, which really, it relates a lot to what you've just said about the difference in how American physicians and physicians in other countries, I guess, view their practice. He said, I don't mind paying a little extra taxes so that more people get health care. Mm-hmm. And I think that's there was a good friend of mine who was a primary care physician down in Surrey in a little village called Elstead. He'd been there for years. He died a couple of years ago. And he had a good life. They enjoyed it. They lived there. They didn't make as much money as we did, but
right.
It's very different.
Yeah, I'd say so. It is in most countries. Getting back to your question about whether you can have a private practice and how much of that's done in the UK or other countries, there are some countries where you can still practice in the National Health Service and have a side practice, if you will, but most countries don't allow that. And even in the United States, if you take Medicare payments, you cannot ask a Medicare patient to pay you out of pocket for one reason or another. Either you're all in or you're all out. I know in Belgium, where I have a friend that practices as a psychiatrist, they're able to have a private practice. I think that same thing is true in Germany. China, I've been there several times to lecture, and from what I can tell, that's really a state-run medical enterprise. I don't see them in private practice.
Okay, let's do a gear. Go ahead.
Let me ask one other question.
Yeah, but
how does different cultures affect psychiatry? For example, China or Japan or South Korea. How is that so different than the United States and Europe in the way you practice psychiatry and approach the issues?
Mm-hmm. Well, talking to psychiatrists from other countries as diverse as China and the UK and Germany and France and so forth, I think that they use pretty much the same medications, and they use the same kind of diagnostic criteria. There's a manual from the American Psychiatric Association on diagnosis that's used worldwide. The ICD-10 system is used worldwide. The same basic illnesses like schizophrenia and bipolar disorder are seen in all countries. There may be different rates of them. Genetics and so forth play a role in some of these things, and they have clusters depending upon the country. But there are huge cultural influences. Let's say if we went down to Haiti and we were trying to understand some of the magical thoughts or delusional thoughts or beliefs about the devil or so forth, that in a certain culture would seem to be clearly a delusion. In that country, it might seem like something that's quite rational to have beliefs in magical kind of mechanisms of why one might get a mental illness or why one might get rid of it. Religion's another thing that plays a big role. There are certain countries that have really strong religions that play into mental illnesses or play into understanding them or treating them or working with them. Others that don't. Even in the United States, say in Louisville, I think that the African-American population is somewhat more likely to not seek out professional psychiatric help and perhaps search for a spiritual connection that may be more important in a way. And those that are Caucasian may be somewhat less likely to do that and may be more likely to seek out a psychiatrist for treatment.
All right. Let's switch gears. One of the in this time of social unrest, one of the issues that's sort of popped up in a number of times is the issue of sending the police out to deal with a mental health issue. And so I guess, the question is, they're saying, well, the police shouldn't be doing this. So I get my question I'm sure you've thought about this a lot and got some views about it, but what other option do you have, or let's put it this way, in the best case scenario, how would you design a system where someone other than a couple of police officers would go out and deal, and I don't even know how you could put this together, a mental health issue? Would it be, you jump in your car and drive out somewhere to Cherokee Park to deal with somebody who's, running around doing something crazy? Or would it be a psychologist, a nurse practitioner, a social worker? There's a million questions about this. So I'm kind of curious to know your views about how this system could be changed so the police who have got a certain focus and would then be not necessarily the first responder or the only first responder in a situation where you're dealing with a mental health issue and not a law enforcement issue.
Sure, I'd be glad to answer that. Would you mind if I take just a moment to give you an anecdote about how I got into trouble as a mental health professional with a person that was potentially violent?
Oh, okay. Well,
all right. You guys don't mind this.
Yeah, it's all right.
Like you, I go back a while. So I served in the military, in the Air Force, right after Vietnam. Spent a couple years in Minot, North Dakota, and I was the only psychiatrist at the Air Force Base, and also helped with the Indian reservations up in that area, and did community mental health because the psychiatrist at the Community Mental Health Center resigned quickly after I got there. So I was a busy guy. So one Sunday morning, I'm at home and I have a couple little kids there and my wife, and I guess we were having breakfast or something. And I get a call from the community mental health worker who was a psychologist. He said, "We've got a real problem. There's a Native American who's down here at this hotel. This is a hotel in Minot, North Dakota. And he's really psychotic and he's out of it, and we don't know what to do with him. Would you come down here and help us out?" And, I said, okay, sure, I'll come down and help out. So I get down there, and it's by that time they have a Sunday brunch, and they've loaded people in from the local around this dining room, and I'm ushered in, and there's a Native American, and there's this psychologist in the Community Mental Health Center, and he's sitting talking to him, and I sit down, And it turns out that the patient, if you will, had been drinking real hard the night before, and he's packing heat. He's got a gun, and it's in his pocket. And he's threatening to shoot up the whole place if we call in the police. So anyway, this was hot water for a psychiatrist to try to figure his way out of this. I mean, I had no training in how to manage anybody with a gun that was going to shoot, right? Psychiatrists weren't trained to do that. The psychologist looked like he was going to have diarrhea all over the place.
FCC.
And I was thinking, my poor kids are going to grow up without a father. So anyway, I won't tell you the long story of how we figured that out, but this guy's threatening, if you call the police, I'm shooting you and everybody else in this hotel. So finally we talked he was getting thirsty, so we talked him into talking to the hotel manager and open up the bar and walking down there to get a drink. So the psychologist was ahead of him and I was behind him walking down to the bar, and this is totally nuts. But I thought we're going to die anyway. So he's smaller than I am, and I was more fit than I was now. So I grabbed the guy from behind and basically just put him in a huge bear hug and told the psychologist to unloosen his belt and drop his pants to the floor, which his gun was in there, which is what we did. And then we called the cops and he got into custody. But it's a miracle that myself and who knows who else wasn't killed in that. So it's a little cautionary tale that I think psychiatrists and mental health workers have to be very careful in managing people who could potentially be violent, because we don't know what to do. We're not armed. We're not managed, how to do that. So we counsel our residents and other trainees to not get into these situations. However, what we try to do, and we're doing this now at the U of L, is we work with the police and train them on ways to understand mental illness, recognize what the signs are, talk people down, try to negotiate with them, if you will, don't inflame the situation, and then in some cases call for help or a consultant who may be able to help you. Dr. Rifal Malik and Dr. Gordon Strauss at the University of Louisville have been involved for years in training the police in Louisville on these de-escalation techniques that they really need to have. So the answer is it's a collaborative work between psychiatry and the police, and each needs to know their role and not overstep their bounds or get into the kind of situation that I was in many years ago and just by the skin of my teeth escape.
Well, listen, if you would you recommend that somebody go along if they know that's a mental health issue? I don't even know how you would know that, but let's just say for the sake of discussion, they get a call and they know this is a mental health issue. Would you recommend sending a social worker or a nurse practitioner or somebody else who has that kind of mental health background along with the police?
If it could be arranged and managed, you got all kinds of financing issues on this too. I mean, who's going to pay for it? The police going to pay for it, or is it you're going to bill the person from their insurance for coming in to try to de-escalate a situation? So that's a tough one. But yeah, and also you need to train the psychologist or social worker on interacting with the police and knowing their boundaries and what they should and shouldn't do. I do know that in hostage situations, having a mental health professional that can advise can be critically important.
We frequently hear, particularly sometimes from politicians, that if we could only screen people who are mentally ill and so they couldn't buy guns, that we would solve a lot of problems. I have two questions. One, do you really think it's possible to do that? And if you did it, how would you protect the HIPAA violations? If a guy's selling guns and then he does a background check, and how's he going to know that someone's schizophrenic?
Yeah, I mean, you're tapping into a extremely important and huge issue. Most of the people that mental health patients that get in trouble with guns, it's through self-inflicted gunshot wounds, through suicide. So access to guns is a big problem in the United States. And I don't want to get into Second Amendment versus, gun safety and prohibition arguments, because that's very controversial. But I can tell you, in trying to reduce the risk of suicide, that anything that could be done to reduce access to firearms is really important.
Well,
when we have patients that are suicidal, the standard of care to ask about access to firearms and to try to do everything you can as a mental health professional to control that access, to have the patient agree to have the guns locked up by their dad or something like that, at least while they're going through the mental health crisis. So I don't know if I'm answering your question, but it is a big problem.
Gene, did you have a follow-up question?
No, go ahead.
Okay, well, Justin, this is in a very similar situation. I think you know that there was a photographer that was shot in the face recently in Jefferson Square.
Yes.
By a guy who was a schizophrenic who happened to get a hold of a gun off somebody who was supposed to be some kind of security person. Now, if you read the article, this young man was on medications. He stopped taking his medications. He was living with his grandparents. They ended up having to take some kind of restraining order out. It's a long story, a long way around to get to the question, but what options do family, friends, or anyone have in dealing with somebody who has got this kind of mental illness, who is not taking their medication? I mean, if this guy had been taken and put into, if you remember that movie, The One Flew Over the Cuckoo's Nest, if you put him in an institution like that, he wouldn't have killed this young person who was there taking pictures. So the question is, what options do people have who have somebody they know who's got mental illness, who's not taking the medications?
Yeah, well, it's again a really enormous problem. You have to balance the civil rights of people versus the needs of the culture and family to control risk for violence. Another intersecting thing is the right to carry guns in this country. There are so many guns out there that it's pretty hard for me to imagine how you could develop a fail-safe way that people with mental illness could not somehow get access to a gun. You ask what options do families have. In our country, in our state, you can't put somebody into the hospital against their will unless there is clear evidence that they are dangerous to themselves or others. So having concern that they might possibly do something doesn't cut it. Otherwise, we'd have warehouse full of people like we did decades ago at Central State Hospital and other places like that. We'd have a one flew of the cuckoo's nest.
But this guy's grandfather knew he had a gun.
Mm-hmm.
I mean, he's not the gun he used to shoot somebody in the face, but he had acquired a gun. He acquired the gun from the check that he got.
He used a stimulus check to buy the gun.
A stimulus check to buy the gun. Yeah. So, but the question is, what option did that man, the grandfather, have? I said he has no option unless he actually takes the gun and pulls a trigger. I mean, you've got a guy who's schizophrenic, he's not taking his medications. They had to get a restraining order because he was coming into the house and beating his grandparents up. And it seems to me there ought to be a way to get this guy off the streets before he ends up doing exactly what he did.
Yeah, I mean, it makes sense that you would try to do that. It's easier said than done. You have to have evidence of imminent danger to hospitalize somebody against their will. And whether that existed in this case or not, I do not know. I mean, I did not examine him. I don't have details on him. I can tell you, having been in the mental health profession for a long time, that these judgments are often hard to make. And we do make them. We put people on mental inquest warrants. We've had people come into emergency psychiatry at the U of L or Norton Hospital or whatever, and the family says this person's dangerous, and we say we agree and put them in the hospital for a while. But you can't keep them in there indefinitely. Once they do better, take their medicine, you just can't keep them in there because they've made a threat in the past. And it's always a tough judgment call. So I don't know if there's a really clear-cut answer to this. Culture has to take a really good look at it. The numbers of guns out there are going to be a problem. Let's say even if this guy would have been hospitalized and he was let go, he's out in the street and he can knock somebody down and take a gun because there are guns all over the place. This kind of thing could happen. I don't know if you gentlemen have ideas on what you think could be done or not. I struggle with this regularly with patients of mine that may be at risk or may have issues that would increase their risk of eventually using a gun. I would say that most mental health patients are not this way. That's a big myth, that there are wild legions of schizophrenics out there ready to shoot the country up. It's not true. The vast majority of people with schizophrenia and major mental disorders are more likely to be harmed by violence than to commit violence.
Yeah, Mark wants to get going there, but let me just say, if anybody's read the Second Amendment, then they know what a crazy situation we live in this country.
Yeah.
Go ahead, Mark.
Okay. Just have a question, Doctor. How can folks access your services? And during a time of all these stresses in our communities, with the pandemic, with the racism, with the just some of the toxic stresses that some of our communities are facing, how do they access services? Does the National Alliance for Mental Illness, I know they've got an office here in town and some programs. What's your best advice on accessing services?
Well, there are lots of ways to get in the door, if you will. It helps to have a referral from a primary care doctor or from a pastor or a rabbi or other religious leader. And those kinds of things help us know as a mental health professional that there's a reason this person needs to get help and we need to do it pretty quickly. I can tell you about access to our service to the University of Louisville. Just go online to University of Louisville Physicians Psychiatry, and you'll see our website and phone numbers to try to get an appointment with us. And we're open for business. We're taking new cases. I would warn you that because of the COVID-19 crisis, we have a bit of a crush on service right now, and we also have people that have been furloughed because of reduced income during this time. So the ability to have someone respond to you right away may not be so great, but ultimately someone will get back to you. For emergencies, University of Louisville Hospital and the Emergency Psychiatry Services is the greatest place to go. Just show up there. If there's a really big problem, if you need help, if you're suicidal or something like that, that's the place to go.
Gene, we got about 1 minute left, so got to make it quick.
Okay, this is a loaded question. In view of the Goldwater Rule and Dr. Lee's book, What Role Does Psychiatrists Under Special Circumstances Have in Diagnosing Politicians?
Yeah. Oh, you did ask a loaded question. So our professional organization, the American Psychiatric Association, endorses the Goldwater Rule, and that we're not to comment on people that we haven't examined, as we have no place in doing that. So not having examined any political figures, or at least ones that I can talk about, I'll have to defer on that question.
All right. I think we're about done here. I want to thank you very much. That was a great discussion. I got to tell you, I am really impressed that you tackled some guy and got his pants pulled down to get rid of a gun. I mean, I'll remember that.
Okay. Sayonara. Good work, fellas. Okay, bye-bye.
Okay, thanks, everyone.
Yeah.
All right.
And for more information about Kentuckians for Single Payer Healthcare, you can go to kyhealthcare.org. And you can also email Kay Tillow. She's the chair at Kentuckians for Single Payer Healthcare at nursenpo@aol.com. Thanks again, everyone. See you next time.
Thank you. Enjoyed it.